Thank you very much for the very kind invitation. And I know the theme of this conference is Ramadan, but I think atrial fibrillation and arrhythmia strike all year round, and there's not a specific flavor. So I want to try to make this a little bit interactive, and I'm going to give you something quite controversial. When is AFib not AFib? I'm going to try and explain this through some nice case studies. Yeah. So we're going to look at arrhythmias that look like AFib on the ECG and some common presentations. What happens if you have a young patient with lone AFib? The role of ablation therapy and why it's very important to refer patients early with WPW particularly. Some disorders associated with AFib that do not have the same left atrial substrate. Also Brugada syndrome, and if there's time, I know this is ambitious, sleep apnea as a major trigger for atrial fibrillation. So what's an atrial tachyarrhythmia? Any arrhythmia, fast tachyarrhythmia, arising above the ventricles, including the atria and the AV nodes, are grouped under SVT, supraventricular tachycardia. Now, there are many examples. Atrial flutter and fibrillation are, of course, above the ventricles, so they are supraventricular tachycardia, but they have specific mechanisms. AV nodal reentry, also known as the common paroxysmal supraventricular tachycardia, and also you have something else called AV reentrant tachycardia and multifocal atrial tach. So this is the whole gamut of actually what we do in electrophysiology, and I think it's important to have a snapshot as you will be the first patients seeing this kind of patient. So atrial fibrillation is a subtype of SVT that is characterized by irregular heart rhythm. It's common, sustained arrhythmia. It's the most common. It's disorganized, rapid atrial activation leading to irregular ventricular rate. As a result, atrial contractility is lost, inability to completely eject blood from the left atrial appendage, and the risk of clot increases and thromboembolic events. Now, the ventricular response, which is the heart rate, is dependent on the conduction of the AV node, not the atrium. So typically, the heart rate can be between 120 to 160. In certain patients, you can go as fast as 200 beats per minute. So the basics of the diagnosis of AFib, just to simplify. Absence of distinct P wave. This is number one. Number two, an irregular interval. Of course, patients on medications, this may be different. It's a narrow, complex tachycardia, usually with the heart rate between 110 and 160, and the QRS is usually less than 120 milliseconds, except if the patient already has a bundle branch block, aberrant conduction, or an accessory pathway. And oftentimes you can find these funny-looking waves called fibrillatory waves that can mimic P waves. So this is where the tricky part is. Atrial fibrillation clinically is classified as paroxysmal. That terminates spontaneously less than 7 days. Persistent, that takes more than 7 days or requires an intervention, cardioversion, for example. Long-lasting is more than 12 months. And permanent, where I'm a cardiologist and I'm an internist and I'm going to say, I'm done with cardioversion. I can't keep this patient in sinus rhythm. And it's a clinical decision. Lone AFib is younger than 60 with no concomitant heart or structural heart disease. And non-valvular AFib, this is an important definition, those patients who do not have severe rheumatic mitral valve disease. This is very important. So, what's the difference between atrial fibrillation and flutter? Do we have a pointer? It's helpful too. Just to highlight it. So the difference between atrial fibrillation and flutter is the organization. So this is flutter, and you see here there's a typical sawtooth pattern. You see it comes up and down because this is not a random process. This is a cycle that occurs within the left-right atrium. On the other hand, atrial fibrillation, there is really no concordant, any kind of atrial activity. I can't have it. Yeah, it's difficult to point this out. Is there any pointer that we can use? Oh, that's fine.
Hamed, any pointer? Do you have any pointers there at the back?
Okay. So to highlight this thing, maybe just the mouse here, you can see these are fibrillatory waves. The QRS complexes are completely irregular, and the P waves are different in shape, size, and morphology, and not predictable, right? So this is the difference between flutter and fibrillation. They're not the same at all in terms of mechanism, and certainly not the same in terms of the definition. So in the atrium, you can have 3 different irregular rhythms. So let's look at this pattern. So the atrial fibrillation above is irregular. You see the QRS complexes are totally different in terms of frequency and duration. Atrial flutter, you have 4-to-1 block, 5-to-1 block. And what is this? This is a trick. This is multifocal atrial tachycardia. Why is it different? Because you have a P wave that looks like sinus. You have a tented P wave that looks like it's coming from the right atrium. and you have an inverted P wave that looks like it's coming from the low left atrium. Is this atrial fibrillation? It's not. It's simply irregular, but there is a organized P wave morphology. Do you anticoagulate number 3? You do not. Multifocal atrial tachycardia does not require anticoagulation. Where do we see multifocal atrial tachycardia commonly? In the setting of acute pneumonia, because hypoxia and pulmonary infections can trigger multifocal atrial tach. So this is very important because you'll see this, and oftentimes physicians will look at the ECG, look, it's irregular, maybe it's AFib. It's not, and it really is different in terms of the long-term management. So the differential diagnosis, i.e. ECG mimics, includes sinus tachycardia, atrial flutter with variable block, atrial tachycardia or multifocal atrial tachycardia, and some more important ones like WPW, AV-NRT, and AV-reentient tachycardia. So we'll try to go through this. Now let's look at this ECG. Really, I want this to be a nice interactive session. There are no Kaplan-Meier curves. There's no guidelines here. Okay? So, is there a P wave? There is. There is. It's tricky. There's a P wave. And where are the leads that P waves are most likely to be best seen? Lead V1 and lead 2, right? That's why the typical ECG rhythm strip is lead 2. So if you look here, there's a P wave here. There's another P wave here. Something happens, it's fast, then it stops, and there's a P wave here. Another big P wave here. It's very strange. It's almost like the P waves are disappearing and reappearing. So is this atrial fibrillation? Probably not, because as long as there's distinct P wave activity, the presence of irregularity is not the main diagnostic criteria, right? So you have to point your eyes always to V1 and to lead 2 and to see if you can see a dominant P wave that is linked to the QRS, okay? So what is the differential diagnosis? Sinus tachycardia with AV Wenckebach, i.e. increasing PR interval. Sinus rhythm with junctional bigeminy, AV-NRT with 2-to-1 block, non-reentrant AV nodal tachycardia, or complete heart block. So let's just take another look. Yes? Okay. So let's come back to this. This is a very, very, very nice ECG because many electrophysiologists were shown this ECG and they missed it. So this actually is a very rare phenomenon. It's called a double fire. Okay? So this patient has, thank you, has both a fast and a slow pathway. So it is normal in the AV node to have two pathways. One of them you see, that's the fast pathway because the PR interval here is short, 200 milliseconds. And one of them you never see, which is the slow pathway because the QRS appears before that. Now in this very strange patient, the P wave generates one QRS and then very slowly goes down the fast pathway, the slow pathway, and it generates a second QRS. So it's one, gives you two QRS. There is no P wave here. Here's another P wave, gives you two QRS complexes. Here's another P wave, and there it is. There it's repetitive. Here it's blocked, so you now see the second P wave generated by the slow pathway. Isn't that fascinating? So in 40% of patients, you and I, we have a dual AV node. One of them is fast, which you always see, produces a PR interval of 200 milliseconds, and one of them is slow, which you never see because the QRS is generated by the first one, right? In this strange situation, you actually see this double fire. One P wave creates two QRS complexes. Very odd. I only wanted to show you this to demonstrate to you what is a dual AV node physiology. And it's common. 40% of people have this. I bet you half the people in this room have dual AV node physiology, but very few will demonstrate this kind of ECG. All right. So let's go on. Is this atrial fibrillation? Okay. Again, what are the leads that you are likely to see a P wave, right? We have V1 and we also have lead 2. Right? So lead 2 is the rhythm strip here. Okay. So do I see in V1 a clear upright P wave? Yes, I do. And then the next beat, there's no P wave. And then the next beat, there's no P wave, right? So as long as you have a dominant P wave in the tracing, it's not atrial fibrillation. Great. So what is it? So, right? So this is actually not AFib. These are junctional ectopics with pre-R prolongation. Another evidence of dual AV node. So when people did electrophysiology studies years ago, they realized that 40% of patients always have a dual AV node. Now let's show you the exact presence here. So this patient actually has sinus bradycardia, right? So the true sinus rate is P wave is here, followed by this beat. Now this beat is narrow. Yes, it's narrow. It's not preceded by a QRS, right? And then you have another beat, which is narrow also, but there's a small deflection here. So you have a P wave here, you have a junctional beat here, another junctional beat here, and another P over here. So you have to look at the whole tracing in order to see what you're looking for. And this is not something you need to be an electrophysiologist to understand. So what is a junctional beat? It is a beat that comes from the AV node, i.e., there is no P wave before it, but because it's coming from the AV node, it is narrow. It uses the normal conduction system and goes to both ventricles at the same time. So in this particular case, you see clearly sinus beat and a junctional beat. And after the junctional beat, there's a slight delay in the PR interval, but you still have conduction. So this is not AV block. This is simply sinus bradycardia with frequent junctional ectopics. Okay? Now, for those of you who are looking, I think you can see clearly that the junctional beat has a different morphology, right? It's upright in lead 2. Why is that? Because it's coming from the AV node. It's not coming from the sinus node. It's not coming from the top to the bottom. It's going backwards. Make sense? All right. So what about this? I've labeled it, so I'm not trying to be tricky. Why is this not atrial fibrillation? Okay? Now, I told you earlier, one of the definitions is that you do not have an obvious P wave. Well, you have a P wave here, you have a P wave here, then all of a sudden the rate speeds up. So what's this? This is actually a paroxysmal atrial tachycardia. So you see here, I don't know if you can appreciate this. The P wave here is what? It's small and it's inverted, right? So is this coming from the sinus node? The sinus node is defined as the upper right atrium. So it's always positive in 2, 3, and AVF, right? These are the higher leads, and it's going towards the foot. Here, it's negative in the inferior leads. That means it's going away from it. So it's not a sinus. It's a ectopic atrial tachycardia, right? I hope this is not mysterious. I want these things to be as, as simple, as clear as possible. And this is also very interesting because the tachycardia enters P wave, QRSP, QRSP, a little bit faster. And then this P wave is not conductive. It's negative, and then the sinus node continues. So this is a paroxysmal atrial tachycardia. It stops on its own, right? Okay. Now, is this atrial fibrillation? Yes, it is. Absolutely. It is atrial fibrillation. It is irregularly irregular. There is some atrial activity, but it's definitely not sinus. It's organized, but it's also very irregular. It's not a P wave here. This is tricky. This is not a P wave, and this is not flutter. Why is it not flutter? Because the atrial activity is irregular. It is fast. There are flutter waves, but they are not the same in every lead, right? So it's definitely atrial fibrillation. It's definitely not one of the mimics we showed you. So just to emphasize the point, the absence of a P wave and irregularly irregular rhythm and irregular atrial conduction and contraction is the hallmark of atrial fibrillation. Now, why in this case does it look like flutter? Why does it look more organized, right? It's a little suspicious. Because the patient's receiving antiarrhythmic therapy. If you give antiarrhythmic therapy, the atrial fibrillation, instead of being completely chaotic, slows down and can be regularized. So this is tricky, but it's still in the same spectrum. Remember, we treat atrial fibrillation and flutter the same way, right? If you have a patient with atrial flutter, do you anticoagulate them if they have a high CHA2DS2-VASc score? Absolutely, right? Do you treat them as if they have structural heart disease? Absolutely. So fib and flutter are very similar in terms of substrate. Atrial tachycardia is not, okay? So, what is the current state of the art in the treatment of atrial fibrillation? It is actually ablation. In the past, many clinical studies showed that you can use antiarrhythmic therapies, amiodarone, flecainide, propafenone, with varying degrees of success. But what is the problem with long-term antiarrhythmic therapy? As you all know, toxicities, right? So amiodarone is the most commonly used antiarrhythmic worldwide. It has 4 major toxicities, which you, I'm sure, know as internal medicine physicians. 1, thyroid dysfunction. Can cause a severe form of hyperthyroidism, thyrotoxicosis. Can cause hypothyroidism very commonly. What other organs does it affect? The liver, the lungs, the cornea, right? So as a part of annual assessment of a patient with AFib on amiodarone, we have to do pulmonary function tests. We're looking for a 10% decrease of the LCO. It's very serious. We also have to do an annual corneal light exam, slit lamp exam, to look what's called cornea verticillata, early deposits in the cornea. We do annual liver function test, and we do a thyroid function test as well to look for toxicities. The long-term toxicity of amiodarone is as such, more than 200 milligrams over 10 years is likely to have 10% toxicity in the lung, liver, or the cornea. What do you do if the patient has toxicity? You send them for ablation, right? So over time, the evidence for ablation has improved, and we have the Cabana study and the Castle AFib study, and many other recent studies that show that early ablation is very effective in these patients because, one, it can eliminate the tachycardia, and two, you can reduce the burden of the anticoagulation. How do we do AFib ablation? So it turns out from early studies in the 1990s that most of the AFib arises from chaotic electrical activity in the pulmonary veins of the left atrium. Remember, you have 2 lungs, you have 4 pulmonary veins, right? Right upper, right lower, and left upper. And if you do an ablation with an encircling lesion, either radio frequency with this lasso catheter or cryoablation, you create a circular lesion, you block the electrical activity to come to the left atrium, and you can eliminate about 75 to 80% of recurrent atrial fibrillation, right? So this is now the standard of care, and now we're doing it earlier and earlier in younger patients because of the effectiveness. So when you do an AFib ablation, do you stop anticoagulation? Anyone? No. If the CHA2DS2-VAS score is elevated, even if you eliminate this electrical substrate, you have not eliminated the atrial substrate. Remember, these patients also have what? Scarring in the left atrium. They have left ventricular hypertrophy. They have hypertension. They have diabetes, right? So the CHA2DS2-VAS score doesn't change with ablation. Only the arrhythmia changes. And you can tell me, well, you've eliminated the AFib. Not completely. 15 to 20% of patients will recur after ablation. You don't know when that's going to happen. And certainly as they get older, the risk of stroke is still there. So when we tell the patient, why are we doing the ablation? To eliminate your symptoms, to improve quality of life, to reduce the AFib. But it's not been shown ever in randomized studies to reduce the risk of stroke. So you have to continue anticoagulation. And that's an important thing we have to counsel our patients. And I know many physicians have atrial fibrillation, and they come to me asking this question. And the answer is CHA2DS2-VAS score equals stroke, AFib equals symptoms. They're not exactly the same. So there's another nuance to this, and that is supraventricular tachycardias, if left untreated, can themselves cause AFib. So this is a very important study, without going into the detail, where they found the following. When they referred patients for AFib ablation, they did an SVT study. They did a complete dynamic EP study. Not simply this, cryoablation, but actually they did a complete EP study. And they found about a third of young patients with low CHA2DS2-VAS score had an inducible arrhythmia. In this case, what do you ablate? You ablate the SVT and you leave the AFib alone. It's not coming from the pulmonary vein. It's being induced by the tachycardia. So here again is another argument for early referral for EP study in these patients. Okay, so going back to the theme of tricky looking ECGs. And believe me, I'm not trying to make this difficult. I just want to show that you can almost always make the diagnosis by looking at the ECG carefully.
Sorry, Dr. Hani, you have 2 minutes.
Oh, sure. So, do you believe this is AFib? I'm not trying to be tricky. Let's just apply the rules. It's fast, it's irregularly irregular, and there is no P wave before any QRS. So this is definitely atrial fibrillation in a young, healthy patient. So what would I do in this patient? I would cardiovert them, put them on a DOAC for 4 weeks, and then offer an AFib ablation. So, one last point here. This is a mimic. Look at this one. I've marked it so it's very clear. This is not atrial fibrillation. Why? Because you have P wave, P wave, P wave, P wave. This is a multifocal atrial tachycardia. Even though it is irregular, and it's irregularly so, if you look in lead 2, you can identify a distinct P wave. So this patient gets an ablation, and this patient does not, right? So I hope I've sort of identified all of these little tricks and reasons for EP and ablation. And I think the key point is not all irregular rhythms are AFib, and some of them have a special mechanism. But if you have a detailed look at the ECG, almost 100% of the clues are available. And thank you very much for your time.